All right, so we are in respiratory. Shep, welcome.
Hello.
You're going to have 12 minutes on the clock from the moment you are dispatched to the moment you provide a verbal report. Any questions?
No.
Okay. You are dispatched to the residence for the patient complaining of respiratory distress. Go ahead.
All right. With respiratory distress, I'm concerned about a possible respiratory infection.
Okay.
Don't want to get sick myself, so I'm going to wear a mask.
Okay.
Respirator.
Okay, like an N95?
N95, yeah.
Right.
And I'm also going to wear gloves for
Okay.
that BSI.
Sure.
How's the scene? Is it safe?
It's safe. It's a quiet residential block.
Okay, I'll enter the residence.
Okay.
What do I see?
Yep. You see a patient who's sitting on the couch, leaning forward with their hands on their legs, visibly in respiratory distress, and they look pale and sweaty to you, but their eyes are open. They're not,
Okay.
they're not lying on the ground. Their eyes are open. They almost they kind of like wave you over. They're like, come this way.
Okay.
Yeah.
So, alert. Then I'll approach and introduce myself. Say,
Okay.
Hey, I'm Shep. I'm with EMS.
Okay.
Got my partner here, so-and-so. We're here to help.
Yeah.
What's your name?
Carol.
Can I call you that?
Yes, you may.
All right. How old are you, Carol?
Carol is 22.
22. What's your sex assigned at birth?
The sex assigned at birth is female.
Okay.
What are the three things prior to doing that?
Oh, shoot. Yeah. Oh, my goodness. Just skipped right on. So, number of patients.
Just one.
Okay. And then nature of illness, respiratory. I'm going to call
Okay.
for ALS as
They're
well.
on the way.
All right. Thank you.
Yep. So you're talking to Carol.
Yeah. What's going on today?
So she pauses every 3 words, but she says that she's been struggling with her cystic fibrosis.
Okay.
And she's been able to manage it in the past, but from time to time it feels so severe that she might need some assistance from an ambulance, from EMS.
Okay. So I'm hearing chief complaint. She has cystic fibrosis and it's gotten worse.
Okay.
And she needs assistance.
Okay.
With breathing. I have some questions that might sound a little silly to you. Do you know where you are right now?
At home.
Okay. Who's the president?
Joe Biden.
All right. What day of the week is it?
Sunday.
Okay. She's ANO times 4. She knows who she is and
Okay.
then answered all the other 3 questions correctly.
Okay.
Did you lose consciousness at all?
I did not.
Okay. Have you fallen today? Hit your head? Nothing
No.
like that. Okay. So no C-spine.
Okay.
Just want to check. And then she looks sick. It sounds like with
Yeah,
the
pale and
paleness,
sweaty.
tripod
pausing
position.
every 3 words.
Okay. Any bleeding?
No bleeding.
How's her airway? Is it open? I mean, she's talking to me. Any
Yeah,
stridor?
no abnormal airway sounds.
Breathing, tidal volume, is that adequate?
Adequate.
Ventilatory rate?
A little fast.
Any accessory muscle use?
No.
Regular or irregular pattern of breathing?
Regular.
How's her SpO2?
It is currently 89%.
Okay. And then lung sounds? What do I hear?
You hear crackles at the bases of the lungs bilaterally, as well as wheezes throughout.
Wheezes.
Bilaterally.
Okay. So she's in, I'm going to say respiratory distress.
Okay.
With that wheezing, I'll put her on a nebulizer.
Okay, so if you have one in front of you, can
yeah.
you walk us through
I got
the
it.
process of what meds, how to assemble everything?
Sure. So the meds are going to be albuterol and Atrovent.
Okay.
The albuterol
The
is
dose?
2.5 milligrams and
Okay.
3 mils.
Okay.
So there'll be a little pack. I'll crack it open,
Yeah.
put it in. And then the Atrovent is 0.5 milligrams, and I believe that's in 1.5 milliliters.
Also 3 mils.
Also 3?
Yeah, they're both equal volume.
Okay. Interesting.
And as a distinction for everyone watching, it's that level of attention to detail that separates good from great.
Okay.
So every time you're talking about a medication, you're not just saying oxygen. You're saying 15 liters of oxygen at or with whatever device, with a non-rebreather. Or if it's albuterol, 2.5 milligrams of albuterol, very rare to hear in 3 milliliters of solution, right? So it's just like that's that distinction that we see from time to time.
Gotcha. So then we've got the mouthpiece.
Okay, that's not the
And-
mouthpiece.
Oh no, sorry. But I'm gonna make the mouthpiece.
Oh,
sorry.
okay.
So,
So if you were to show, yes.
I'm gonna set it up.
Okay.
All right. So that side is And then here's what actually goes in the mouth.
Oh, okay.
Sorry.
And then how would you assemble that to the chamber?
And then I attach it to the chamber.
Very good.
And I've got my
O2 tubing?
O2 tubing.
At what flow rate?
And it's going to be, I don't know, some people have told me different things, but 6 liters per minute for the purpose of this class.
Strictly 6.
And then you're going to see some mist, and I'll tell the patient to put this in her mouth and this side, and take like as deep a breaths as she can.
Okay. So she's currently holding that. And how do we proceed with our assessment?
So we're going to go to circulation.
Okay. Yep, there's no bleeding. What else would you want to know in circulation?
I want to see skin.
Pale, cool, diaphoretic. Okay. And how would you ask that? I cut you off. How would you ask that?
I'm looking for color, temperature, and conditions, like if it's dry or...
Okay, very good.
I specifically like the conjunctiva, or the conjunctiva.
Yeah.
Color.
Pale, cool, diaphoretic.
Okay. And then pulse.
What about
I'm
the
going to feel for strength, rate, regularity, and equality.
Okay. Weak, rapid, regular, and equal.
Okay. And then cap refill.
Under 2 seconds.
Given the skin conditions and her weak and rapid pulse rate, I'm concerned that she's in shock.
Okay.
So we're going to keep her warm. I'm not going to lie her flat because she's having respiratory distress.
Okay.
And with the rolls, it'll get worse.
Okay.
We do that. But I will... she's on the oxygen treatment.
Yeah. So what are the 3 things for shock treatment?
Shock treatment, keep them in a position of comfort or flat if they don't have respiratory distress.
Yeah.
Keep them warm.
Okay.
And then put them on an oxygen treatment.
Very good.
So we're doing that. Any environmental concerns in the house? Is it really hot? Is it really cold?
No, it's a mild 72 degrees.
Okay. So no concerns for hypothermia or hyperthermia there. She is unstable with the shock and then the respiratory distress. So we want to transport her right away and do everything else.
We're in the ambulance.
All right. I'm going to do my history, or her history.
Okay.
Onset. Did this come on suddenly or gradually?
Gradual.
Does anything make it better?
It helps to sit up, if not lean forward.
Okay.
And then it gets worse when I'm flat on my back.
Okay. What does it feel like?
Feels like I have some blockage in my lungs. It's very hard to breathe, and occasionally I'm coughing some mucus up.
Okay. You said that this happens sometimes. Mm-hmm. How does it feel compared to previous?
Worse, but I'm able to cough things up, and not so much right now.
Do you have any discomfort anywhere else?
It's general discomfort everywhere.
Okay. How bad is it? A scale of 1 to 10.
About a 6 or 7.
When did this start?
30 minutes ago.
And then I'm going to look for associated signs and symptoms. So any peripheral edema, swelling in the hands and feet.
No.
Do you have any chest pain?
No.
You said you have a cough?
Yeah.
Right? Okay. Do you have a fever?
No fever.
No fever. Any weakness?
No, like mild weakness.
Mild weakness. Do you have any allergies?
No allergies.
Are you on any medications right now?
I used to take albuterol. I can't find my inhaler. And then from time to time, I would be on a round of antibiotics for my cystic fibrosis.
Gotcha. So you have the cystic fibrosis. Any other medical conditions?
Asthma, and that's it.
And that albuterol inhaler, it's for the asthma?
Yeah.
Okay. When's the last time you ate or drank anything?
I had a bagel a couple hours ago.
What was going on when things got worse?
Just doing the mundane day-to-day chores in the house, and it's been building up over time, and it just got worse this morning.
Okay. How long has it been building up?
Over the last few days. Yeah.
And then I'm going to ask a few other questions. So that cough, what comes up when you cough, if anything?
About clearish, whitish mucus.
Do you have any other signs of a respiratory illness?
No fever, but just the productive cough.
Okay. You said the symptoms get worse when you lie down. How about when you are trying to sleep at night?
Same, yeah. I can't sleep on my back.
And then, all right, I'm going to look for JVD.
Not present.
Tracheal tugging.
Not present.
Or accessory muscle use.
Not present.
Any peripheral edema.
Not present.
Drooling.
Not present.
Pink frothy sputum.
Not present.
Tripod position.
Not present.
Oh wait, no. What am I doing?
It's okay.
Pursed lip breathing. There we go.
Not
I
present.
was trying to do a cardiac assessment for a second.
Okay.
And then secondary skin conditions.
Pale, dry, and not diaphragm. Pale, cool, and dry.
Okay. Lung sounds?
They are still rails. The wheezes have diminished.
Okay, but still present?
No.
No.
Well,
okay.
Yeah, let's say they have. They're still there.
Okay.
Wheezes and rails bilaterally.
Okay. Is she still on the neb treatment?
It's over by now.
Okay.
And let's say you wanted to give another one.
Yeah, I might give another one.
And upon your reassessment, wheezes still persist.
Okay.
Wheezes and
After
rails.
the second.
After the second one.
All right. Where am I? Tracheal deviation, I'll palpate for that.
Okay. Not present.
Vitals, so BP.
BP is 160/82.
Heart rate.
Heart rate is 98.
Vent.
20.
Pupils.
They are pearl.
SpO2 now.
SpO2 is 90.
Okay. Given that she's got the rails, the crackles, and her SpO2 isn't improving a ton on that neb, did you say she still has wheezes?
Yeah, wheezes and rails.
Okay, so I'll put her on CPAP with inline nebulizer.
Okay, show
So
me
we've got-
how CPAP works.
We got this CPAP device, and we're going to put O2 through here. It'll be at 10 liters per minute, and then you
Okay.
can control the PEEP.
So it starts at, there's like three
So it's
levels.
like-
It's like
yeah.
5, 7.5, and 10. You
So
start
we'll
at the
start-
lowest. So PEEP is just positive end expiratory pressure, and it helps maintain the compliancy and integrity of our alveoli.
Yeah.
But because we have persisting wheezes, you're saying you want an inline neb. What does that mean?
So there's a little,
Like a one-way
yes,
valve.
a one-way valve.
Yeah.
Okay. At the bottom here.
Okay.
And we can put more medication in this neb.
Yep.
And we'll just attach it here.
Okay.
So we have one tube supplying oxygen
Okay.
to the CPAP.
Yep.
And then one pushing air through the nebulizer.
Okay.
So she's going to get she's going to get the medication
Yep.
plus the positive pressure.
Okay. Very good. Anything else? So what do you think was going on with this patient? What was the field impression?
My field impression is that she has an exacerbation of her asthma potentially, plus the cystic fibrosis.
Yeah.
Some combination of the two.
Okay.
And then, given that she said she feels like she is having the same things that were going on when she had pneumonia in the past, I'm
Yeah.
worried about pneumonia potentially.
Okay.
So
How often would you reassess, and what are you reassessing?
I'd reassess every 5 minutes because she's unstable with the respiratory distress and the shock. And I'm going to be looking for repeating the primary, so ABCs.
Yeah.
I'm going to do vitals.
Okay.
So especially the BP and her respirations, SpO2, heart rate. And check those interventions, see how the CPAP is doing, how it's feeling for her, and then I'll assess her chief complaint, see how she's feeling.
A lot better.
Okay,
with
great.
the CPAP. When you're ready for a radio report, go ahead and give a radio report.
Okay. I'd say, hey, hospital, whichever one we're going to. This is Chicago EMT training, ambulance 1. How do you copy?
Loud and clear.
We're 10 minutes out with a 22-year-old female, the history of cystic fibrosis. She has the chief complaint that her symptoms have gotten much worse over the past few days, and she usually is able to clear them and manage them on her own, but she was not able to do so today. She's A&O times 4. When we first saw her, she looked pretty sick. She was leaning forward, tripod position, pale, cool, diaphoretic. When we auscultated the lungs, she had crackles, wheezes, and her SpO2 was 89%, so we put her on a neb treatment. That didn't clear the wheezes, so we put her on a second, and then She still had wheezes after that and was continuing to have difficulty breathing, so we placed her on CPAP after getting a BP on her.
Yeah.
She also presented with some signs of shock. She was pale, cool, diaphoretic. She had that weak, rapid pulse.
Yeah.
So we're doing shock treatment. Like I said, she has a history of cystic fibrosis and asthma. She usually has an albuterol inhaler, but she couldn't find it, and no known allergies. And I've got vitals for you if you want them.
Please.
BP 160/82, heart rate 98, vent rate 20, pupils are pearled, and her SpO2 is 90%. No, sorry, what's her SpO2 now?
95.
95% on that. CPAP. Any further questions or orders?
No. See you in, how long? 5 minutes?
10 minutes.
10 minutes? See you in 10 minutes. That was great, Shep. That was awesome. How'd you feel about it?
Okay, yeah. I tried to do a cardiac assessment in there.
Oh, yeah.
But otherwise, yeah. I think I forgot blood glucose, too, on the vitals there.
Right,
but.
yeah. Wow, that was great.
Thanks.
That was great. That was, in my perspective, ideal if someone can nail that when we actually do it in respiratory cardiac. Because our difficulty as instructors is providing context or a reasoning why this is so important. A previous student that came on said that it finally clicked at Unit 3 when we did neuroabdominal and immunology. And as an educator, I'm like, that's late. Like, we want you to know the patient assessment much sooner. And so how do we emphasize the importance of the patient assessment skill much sooner?
How?
Yeah.
I think what helped me is the fact that I had to do clinicals. Like, I started my clinicals kind of early, and that made me
Which is
have to
interesting,
practice.
because how valuable were the clinicals if you didn't know the assessments? I mean, you knew respiratory cardiac, but
yeah,
like all the other ones. Neuro, abdominal pain, immunology.
I told my preceptor up front, I was like, this is what we've learned, so these are the patients I want to see.
Oh.
So I can do cardiac and respiratory, and I want to practice that. And that gave me the foundation to then learn more.
Did you have a certain game plan as far as which clinicals you wanted to do first?
Not really.
Okay, you didn't really care.
Yeah.
That's so interesting.
Yeah.
If someone was watching this for the first time, is there any advice that you would give that student if you were to try to reflect on the importance of that patient assessment skill earlier on?
Practice with other people.
Oh.
Practice with other people. Like, set up time to meet, like, if it's over Zoom or whatever.
Yeah.
Because you can do it by yourself and you can, drill it as much as possible, but unless you have someone actually telling you the information about the patient and kind of throwing off your thought process.
Which is also difficult because even as students, when we are back in respiratory cardiac, we don't know the associated signs and symptoms, so it's hard to give appropriate responses within a scenario.
That's fair. There's a ton of scenarios online. You can just Google.
Google?
Truly Google, EMS cardiac assessment, and you'll find NREMT assessments, and
Very
so
cool.
you were finding them online.
Okay.
Yeah.
Okay.
No, we weren't just making them up.
Which I mean, at that point in time, the main thing is to just commit to the flow of scene size, abdominal impression, ABCs. How much time did you spend on that if you were to reflect on it? And I'm sure it gets easier over time, but in the very beginning, how much time do you think you actually spent?
I don't know. It's hard to say. I have a dog, so I'd walk her, and I would be doing the general medical assessment, just in my head.
Wow. Okay. So in your free time, or your main time.
I'd be oh, I have some time here. I can just run through it in my head.
So it's hard to put an actual number to it.
Yeah.
Meaning you're always studying.
No. Just when I'm bored. I mean, they're long walks. They're long walks. So,
Okay.
I don't know.
Is there any other maybe intangible advice, maybe soft skills that students should come in with to set themselves up for success?
That's a good question.
Because we've had students with various levels of prior healthcare experience or people that crush it in university that struggle in our class.
So I have a background as a paralegal, and I worked with people who were dealing with evictions. And I was surprised that my experience talking to people who were dealing with very stressful life events that weren't had nothing to do with medicine, allowed me to be comfortable finding ways to empathize with people in the moment and say things that showed that I was actively listening to what they were saying, was so helpful in assessments with actual patients, because I had these skills to be able to then put them at ease and ask them, or like get the information that I needed to get from them.
Yeah.
So I think like focusing on listening to people and paying attention and slowing down enough to treat them like human beings, which can be, I don't know, can be hard when you're trying to like apply the new information
Think about
that you
what
have.
what to do, right.
And then get everything you need to do, and also see the person as a person.
You almost see these soft skills as a luxury.
Yeah. Or they take
But it's
time
a
to
necessity.
develop.
Yeah.
Yeah.
Okay. Appreciate the time. That concludes our respiratory assessment. Thank you, Shep. You will forever be memorialized on YouTube.
Oh boy.
Catch us in the next video. Bye.